for today's meeting, we will also be joined by members of our Mirror Board. First item of business then, conflicts of interest. May I ask board members please to raise any new conflicts or conflicts relevant to today's agenda? I'm not seeing any hands. Thank you very much. And then the minutes of our last meeting held in public on the 21st of November and the matters arising. Any comments, questions? No, thank you. I will take those as an accurate record. Let me hand over then first to our Chief Executive, Fiona Edwards. Thank you, Fiona.
Right, hello everyone, lovely to see you all, and a happy new year. And it's just really to reflect on some of the great work that we're doing, but also the challenges that we're really facing together across the whole system with partners. So partnership working and collaborative working is a core theme and vehicle for the Frimley system, evidenced by our focus around leadership and culture and the investment that we put into that, and also our integrated care partnership assembly working, which met just before Christmas at the end of last year. So sometimes it's a real challenge to hold that course, but evidence of holding that course is now the establishment of the Mirror Board, of which we've got members here, which is both an innovation and a progression of our focus around creating opportunities and development spaces for all, and testing our inclusive approach, and testing holding true to our core purpose and priorities. So it's great that we've now started on that journey and it's up and running, and it's real evidence of that transformation and innovation capability that we hold close to our hearts while still meeting real challenges, especially this winter with the ice lying thick on the roads today, and I'm looking at quite a heavy frost as well. So and that said, we've just come out of, and we'll focus on it in our performance discussion, of the longest period of industrial action by junior doctors for ever experienced in recent time, in the middle of winter at a time of usually peak demand. So people are really stretched. I have to thank all colleagues across all our partners for the joint work that we did to lead into the Christmas and New Year period, the stepping up of additional services like our 2 urgent care centres in Slough and North East Hampshire, and the opening of an additional facility in Heathlands last week for additional bedded capacity to be able to move people out of hospital acute care more rapidly. So and we are doing really well collectively on whole system discharge management and the join up there, and the fact that we're one of the few systems that have a jointly owned discharge dashboard. We're one of the highest performing systems in terms of use of virtual wards and remote monitoring, all of which to try to help get our response right. And our primary care colleagues have really stepped up with additional capacity. They've been crucial in partnering with us for the urgent care centres, but are also continue to be a very high performing in being able to provide access to the public. And that is linked to a lot of that being virtual access, but it is still it means that people are seen really quickly. So those are all the great things that collectively we're doing and the challenges that we're meeting. We as all partners across the system are facing significant financial challenges. We hear stories about local authorities in the country, across the country, finding it very difficult to balance their books, and that the same applies to the NHS this year. And we have actively had to take a look at how we meet our financial duties collectively across NHS providers and in the ICB this year. And also the Integrated Care Board are going through quite a significant restructure and reorganisation to reduce our cost base, which impacts directly on our staff in the Integrated Care Board, who have been fantastic and have responded incredibly well to us doing a major change that affects people's jobs, puts people's jobs at risk, whilst managing everything I've described before. That said, demand is still really high, and I'll leave it to Neil to describe in the performance section how stretched and full the hospitals in the Frimley system are, and that's driven by real issues in terms of usual winter pressures, but also increased from year on year. And it's people have come out of industrial action and are exhausted, but are still trying to respond in the best way possible. And I think that's it from me, Pri.
Thank you very much, Fiona. Are there any comments or questions from that? Initially, we're picking up all of those issues in the course of the agenda. Let me move us then, please, to the first of our substantive items, and that is our quality presentation to our Chief Nurse, Sarah Bellas. Thank you, Sarah.
Thank you, Chair. As everybody had an opportunity to see the presentation, I'm not going to attempt to try and share it. So if you want it shared, one of the team will have to do it. Oh, there we go. Look, it's all a bit too scary if I do it. Okay, if we slip to the first, slip through the things, thank you. We'll just give you a bit of an overview of what we're going to look at. And then if you move to the next slide, I've just given you what the definition of quality is, and the next slide. And then on to the next one. So I think the big thing that we've been working on from a quality perspective is looking at the financial recovery through a quality lens, because it's a significant amount of money, and Rich has explained that in detail, both in the private and the previous public board, that we've had to look at how we make significant savings in year without trying to compromise on quality. So we've had a really great response where every single quality initiative, or every initiative that we looked at, we've completed a quality impact assessment for, and we've held 2 system quality meetings to review them, and had really great attendance, despite one being put in just before Christmas and at very late notice. So thank you everybody that attended, so that we can try and understand. I think the conclusion that we came to from a quality perspective in relation to the initiatives that we will be doing to meet the financial recovery is that where they impact on services, it's a pause in a service, and whilst it won't have impact now, if that pause were to continue, that could have a significant impact. And so we, as we go through this next round of planning, we'll need to review that in that context in order to make sure that we continue to maintain quality and safety. Do you want to go to the next slide? Just give you the details of what we've done rather than the actual flavour of it. So as I said, you know, we will need to continue to look at it. If we move to the next slide, please, and go to quality hotspots. One of the biggest things that we've been working on this year, and it's due to go live on the 1st of February. If you recall, last year I brought to the board a quality of risk around our children's community adolescent mental health services in the south that had previously been provided by Sussex Partnership, commissioned by Hampshire for us, and it made a very disparate connections for our young children trying to use those services, and because of the location of the services and everything else, our children were the most poorly served across the Hampshire patch. So we've been working to try and move those services, and we've been fortunate enough to be able to secure them with Surrey and Borders partnership, and this is great because they already provide our adult services, so we'll have seamless adults and children's services. So it's a really great initiative for us to be doing, and we will be moving slightly ahead of the Hampshire project, which goes live on April the 1st and going live on February the 1st. And it's not like any transfer, it's not without its risks and challenges, and we've been working really hard with all of the providers to mitigate those challenges. So I think obviously we've been completing due diligence, working out the logistics of it. We have operational groups that meet on a regular basis, and this has got clinicians and operational managers to ensure the safety of the transfer of the staff, the transfer of the services, and making sure that everything keeps going. Can we move to the next slide? Some of the transfer risks we've got are around digital electronic patient records, and we're making sure that we get that right. And that's been quite a challenging piece of work that has been ongoing and is still very live at the moment. There is a risk around the medical workforce due to the additional geography, and again we're looking at mapping that and the on-call arrangements going forwards. And we're working very closely with Surrey and Borders in order to make sure we've got those functions covered. And then there's a general workforce challenge that we've been managing around this, but we wouldn't expect not to have these challenges. It's a really big transfer of services, and it's important that we do understand what the risks are and how we're going to mitigate them. Move on to the next slide, please. The other area, and Fiona's kind of alluded to it, and without trying to steal Neil's thunder even further, I'll try not to cover it off, but it's probably the other biggest area of concern from a quality and safety point of view is emergency and urgent and emergency care, and what we're trying to do to manage safety in these times. And we work very closely with the Frimley Health Foundation Trust to look at it. We look at the key quality metrics. Lots of other metrics are looked at, but the things that we look at other things for patients. So some of the things that we look at are ambulance handover times, making sure that those ambulances are able to get out and get back to patients in the community because they have no care. So it's making sure that we get those handed over quickly, looking at things like corridor care, and trying to understand that and making sure there is safety around that. Boarding, this is where you have to put additional patients into wards when you're expecting discharges, and we've been watching that very closely over the last few days, looking at the policy, making sure we're continuing to do it, and the senior nurses within the trust continually walk the wards to make sure that this is maintained. And there's some of the key things that we look at, and we look at these on a daily basis, trying to identify for effects of harm. We can go to the next slide. The other, that we look at, the other things that we've been looking at is frequent attendances, those in custody, patients with frailty, patients with mental health problems. We've been, we're about to commence a new piece of work with the regional team, looking at how long patients wait before they get moved to specialist mental health placements. There is now a new escalation protocol that after 48 hours, as system chief nurse, I need to be aware of to see what we can do. And if a patient were to wait as long as 72 hours, it gets some attention from the national and the regional team. And we have seen actually an increase in the speed of which that patients are moved off. One of the things that we raise as a local collective of chief nurses, if we're looking at patients in the acute waiting for mental health patients, we also need to look at the patients within the mental health trust that are waiting more specialist provision, which is our higher risk provision like tier 4, because actually those patients are as equally important to look at as other patients. Can we move to the as patients with physical health conditions? And so we work with with all the people measuring all these things, as I've talked about. Can we move to the next slide? I just wanted to give you a little bit of CQC compliance across our system. As you can see, we generally have really good compliance. We've got one of our main providers is outstanding. The other three providers are rated good. The two services that are rated inadequate across health are the ambulance services, and they're across multiple systems. And I think there is challenges across ambulance services in general, and there's lots of work both on a pan system, regional and national level to look at how ambulance services operate and to support them to make that compliance and be good. From a primary care perspective, we don't have any practices in the system that are inadequate. We've got 3 that requires improvement. The overwhelming majority of our practices, 63 of them, are rated good with the Care Quality Commission, and we have 1 outstanding primary care practice within the system. I've listed the nursing and residential and LD homes for people just to have a look at, just to see what the provision looks like. Obviously, we don't monitor that's kind of local authority monitoring, but it just shows you that the standard of care and that compliance with CQC across our system. We move to the next slide. And then the last thing I wanted to talk about was the outcome of the FHCFT maternity CQC. I think maternity services generally are struggling with CQC compliance, and it was pleasing to note that the maternity services at Frimley were rated earlier in May 23, and the outcome for that was very pleasing. So I think the report was published in September and overall good for both sites. So that was really positive, and not to be underestimated, the challenge in achieving that good in the current context of what's required. If we move on to the next slide, I think that's probably all we're going to share today. Are there any questions?
Thank you very much, Sarah. Rachel.
No, we're just a couple of weeks away now from that CAMS transfer, and I'm very assured at the attention that's being paid to the risks and the mitigations there. I wonder whether you could say anything about the communication to young people who are open to the service at the point of transfer, and also to the community that the new service will be serving, so, just about what their awareness is of the change.
I'm not as cited on the communications, Rachel, but I can find that out and bring that back to you.
Thanks. It's just one other element of risk, isn't it?
Yeah, it absolutely is. And I know it in the back of my mind, and I've actually heard it, but I'll be telling you something that's a little bit more made up or off the hoof. I'd rather give you the full facts.
Thank you very much. Come in, Alex.
Yeah, I'm just really pleased to see that the kind of sensible integration opportunity has been taken with Surrey and Borders to land this outcome, and it sets context for our provider selection regime discussion a bit later on the agenda. So having residents and the population in mind in terms of where best to sit services.
Absolutely, Alex, and you've got to learn from the past about where services are run from long distances. It becomes a challenge, and this is the way our population flows. So Surrey and Borders are absolutely the right choice for our population locally on the south.
Thank you. I've just seen in the chat, Ilona, you're not able to unmute. Are you able to do that yet?
I think I am now, if you can hear me. Yeah, thanks, Ollie. It's resolved itself, but I don't know what was wrong to start with. I didn't do anything to fix it, but it's fixed.
Good, thank you. All right. Any other comments or questions in relation to quality in its broadest terms, not restricted to those items in the report? Thank you, and thank you to the work of the Quality Board. The cross-system engagement and leadership within that is really vital and great to see. Thank you very much. Let's move then to the next agenda item, which is the new provider selection regime. And I will go to Richard Chapman, our Chief Financial Officer. Thank you, Richard.
Thank you, Chair. So the paper circulated describes the provider selection regime, which came into force on January 1st. And I guess fundamentally changes the way in which the NHS procures services. Just to update the board, so a proposal to implement the requirements locally has been discussed at the Finance and Performance Committee, and iterative work is underway to inform a February board finalisation and sign off of the formal procurement policy. The proposal is to implement a compliant provider selection regime system with minimal additional governance limited to that which is necessary. The recently implemented contracting system, Atomis, will inform portfolio and place boards of contracts which are expiring, and portfolio and place boards will hold responsibility for the review of expiring contracts, for decommissioning or recommissioning decisions in line with agreed policies, recommending a procurement approach which is compliant with the provider selection regime, and the quality, equity and impact assessments of recommended decisions. The System Resourcing Group retains responsibility for agreeing budgetary envelopes on new or renewed financial commitments, and a new provider selection and contracting group reporting to the Finance and Performance Committee will hold delegated responsibility for contracts up to £1 million per annum. And that group becomes the decision-making forum that agrees the provider selection approach for the ICB and oversees the contract management cycle, reporting, as I say, into Finance and Performance Committee. Contracts over £1 million in value per annum will be held directly by Finance and Performance Committee, which will hold oversight responsibility and escalate to board as appropriate. In terms of next steps, we will be, so following a discussion at Finance and Performance Committee last week, we will be obtaining approval to the proposed PSR process, incorporating feedback from that meeting. We will gain final approval of terms of reference for the PSCG and its membership, and ensure alignment between the procurement process and the standing financial instructions and scheme of reservation and delegation. So that kind of covers the governance bit. In terms of communicating and training, we are building a communications and engagement plan, and training sessions will commence this week on Teams to improve the awareness of the PSR and on how it's being implemented by the ICB, with initial training sessions for portfolio leads happening as we speak. We will issue an initial procurement update of all expiring contracts, including the recommended PSR option to portfolio and place leads, and prioritise and schedule contracts for PSR approval, focusing initially on contracts that expire on or before March 31st. The board is asked to note the changes in the legal framework for sourcing service providers and the intention to bring a revised procurement policy to the February board meeting, and the board is asked to endorse actions currently being taken to implement the new statutory framework in line with that requirement. Happy to take any questions on that, Chair.
Thank you for that clarity, Richard. Questions or comments? Alex.
Yeah, as Finance and Performance Committee Chair and as a provider partner member, I'm really pleased to see this governance coming through. It's very clear. And when we look across other ICSs, I think this is a bit of a benchmark about how you start up PSR in ICBs. I think there's a wider strategic discussion acknowledging that this is the 1st of January commencement, and PSR brings in scope council commissioning decisions as well around public health contracts such as sexual health and health visiting, wherein there are significant integration opportunities and opportunities to do best for our residents and population. So in due course, not immediately putting council colleagues on the spot around the table here, but how are our local authority colleagues implementing PSR? So I think there's a view we need to maintain strongly between ICB and local authorities around the integration agenda. Thank you.
Thank you. Really clear opportunity for us, and underpins much of the sort of transformation work as well that we are undertaking, and to be sure that we're supporting that as well. Invite any comments from our local authority partners if you would like to. Otherwise, I will move us. Gráinne, thank you.
Yeah, thank you. No, and I'm hearing on one hand, really, really exciting, provides wonderful opportunities, and in essence, being a lot more efficient as well, I would argue. But equally, from our local authority colleagues on the local authority side, I think there are going to be some challenges for implementing this. So I know that across Berkshire, we're looking at how local authorities consider what the changes are ahead. But I'm sure that embracing the public health opportunity in terms of contracts will be something that will be warmly embraced by our public health colleagues. I do note, though, that the context of social care is out of scope from this. So I think it is important from both sides, from the public health side, governed by local authorities currently in the majority of contracts, and then from the social care side, where health are often involved, that integrated approach to this is going to be vital moving forward from both sides, isn't it? So important that we do continue to communicate about what the broader implications are about these changes in its entirety.
Thank you. Any final comments or questions? Thank you for that clarity, and noted both that it is implemented and the opportunities across all of those areas for us. Good. Let's move then to our next agenda item, which is our board assurance framework. And Richard, you're taking us into that as well.
I am. Thank you, Chair. So the board is asked to review the board assurance framework, noting the updates to actions that have been taken since we last reviewed the document together in November 2023. Excuse me one second. So in particular, board is asked to note that 3 of the 4 strategic objectives continue to remain outside the board's identified risk appetite and thresholds, and to note that the principal risk for hosted pharmacy, optometry and dentistry, which sits within the delivering work and transformation strategic objective, has been further mitigated from its previous score of 16 and now has a risk score of 6. The overall risk for the transformation strategic objective remains within the board's identified risk tolerance, but for quality, people and finance, the risks are currently outside of the board's identified risk appetite. The board is asked to review and to agree its updated board assurance framework, Chair.
Thank you, Rich. This is an important piece of consideration for us in relation to these areas of risk. Ilona, thank you.
Thanks. Thanks, Rich. Really helpful update, and good to see this becoming a kind of routine part of our assurance process now. My question was really to go back to the one you flagged, where we've got some risks that we're holding outside of our excuse me, agreed level of appetite or tolerance. And I know in the more detailed pack we highlight additional controls that we're in the process of putting in place. I just wanted to check if it's kind of management's view that once those additional controls are implemented, do we expect to see these coming back to a level within appetite? Or do we actually think we need to go further than what we're articulating here? Because I, as a board, I guess we want to just be very conscious where we think we will be potentially taking a level of risk beyond the one we've considered acceptable for a prolonged period of time. I mean, if it's a blip here and there and we're doing something to get it back under control, fair enough. But looking, for example, at the finance one, do we think what we've outlined will bring it back under? And same question really for the other ones which are currently flagging outside of our appetite. Thank you.
Do you want me to come back in on that, Chair?
Come back, Richard.
Thanks, Ilona. So I think the planned actions that we have described are a description of that which is within our control to bring the risks back into the risk appetite tolerance identified by the board. Clearly, at this point in time, we don't have planning guidance or final planning guidance for the 2024-25 financial year, which starts in April. Much of that which is outside of our control will hang on that planning guidance. So I think I'll be in a better position to answer that question more fully once that guidance is finalised. And we have taken it in, interpreted it and translated it into its impact on risk. So I don't think at this point in time I can say that the actions that we have identified will bring each of those three risks back into what the board considers to be tolerable levels. I do think that they address what is within our control to bring them back within tolerable levels.
Thank you, Rich. Come in, Fiona.
Yeah, I think your point where you say for how long do we sustain this? I think that has to be a board discussion when we so our primary vehicle for addressing these risks is our in-year recovery, which we're working on and have got sufficient potentially, but we're just finalising that, as you're aware. And then the planning for next year is the other vehicle. And I think that's that when we bring that through to the board, we need to look at that alongside our risk appetite and risk threshold and use that as the vehicle for a judgment as to is this sustainable or not, and what do we do about it. So I think it's a hold at the moment prior to us considering next year's plan.
Great, because I just think we want to avoid a situation where almost by default we are taking higher risk than we've said we are comfortable doing as a board, because either things have changed, you know, the context has changed, we can't control the things we thought we could control as effectively as we hoped, etc. So I just wanted to avoid a situation which you often see where things are outside of a level of tolerance and stay there. And what that means is we should rethink our risk appetite and or be pushing, you know, escalating in a different way. But it certainly makes sense timing wise to review that once we've got a better handle on next year's plan. Thank you.
Thank you, very helpful. And we'll diarise that obviously as part of the continual review of the BAF. And that element of review of risk appetite, I think, is a really important one for us in this next period of transformation as well, and where that risk is being held and how it is monitored over that time. Thank you very much, everyone. Any other comments in relation to the BAF? The BAF reflects current priorities and work, and we are confirming as well that the current risk appetite and scoring is accurate and owned by the board. Let's move then to our standing items, and we're going into the integrated performance report. And Richard, I think you will lead us into this along with comments.
I will, Chair. Thank you. So I'm going to narrate the integrated performance report. So the system deficit as at month 8 totals £10.6 million, and that constitutes an £8.1 million adverse variance to plan. The system is still forecasting to break even as at month 8, but delivery of that target is heavily reliant upon high risk mitigations. There remains demand pressure throughout the system, and performance has been adversely affected by industrial action in some key areas, including cancer. Out of hospital care remains pressured, but the system is responding with additional capacity in primary care and with virtual ward and remote monitoring rollouts, which are amongst the strongest in the country, and with strong urgent community response performance to alleviate the pressure on our acute providers. In terms of financial specifics, so the ICB is seeing pressures in continuing healthcare, in prescribing, in planned care, and in children and young people's contracts, and FHFT is seeing pressures in agency owing to industrial action and escalation to meet the urgent and emergency care demand which is being seen in the system. In terms of workforce, so the system is making very good progress in terms of temporary staffing. FHFT has reduced agency spend as a percentage of pay from 6.7% back in April to 3.9% in the latest available data. But in performance terms, those pressures are really kind of materializing, in particular, and despite the medically fit for discharge discharges increasing to over 1,000, in fact nearly 1,100 in December, we are seeing 14-day stays increase, and that is having an impact on the front door of the hospital, with attenders over 12 hours higher than we would like to see, and 4-hour waits much lower than we would like to see, and ambulance handovers on average a little bit over the 30-minute target at 31 minutes 24. In terms of planned care, referrals are largely level year on year. 65-week waiters are falling, but we're not currently impacting 52 or 78-week waiters. And diagnostics, shorter than 6 weeks, are improving, but falling short of the 95% target. Cancer performance is falling, but that is related partly to industrial action. Primary care is seeing 80% of appointments on the same day and 90% within 14 days. And 60% of those are face-to-face attendances. In community, we are at 91% occupancy on virtual wards, with 450 urgent community response referrals accepted in October, the latest available data, and 74% of those seen within 2 hours against a target of 70%. Learning disabilities, there are 15 adults in inpatient care against a target of 10, and 84% of children and young people supported by a key worker on the dynamic support register. For adult mental health, acute admissions at BHFT and SABP are opal green and red respectively, and non-acute both providers are on red. In children and young people, eating disorder waiting times are improving, but the mental health median wait time has deteriorated with the latest available data. Board is asked to note the financial and performance report for the system, Chair. Sorry, Ollie, I think I'm out of sync with your slides. Take them down now.
Thank you. And while we take those down, come in, Sarah, please.
I don't know if you want to take any other questions, but I've got an update on the comms plan.
Start with that and then we'll open up.
Okay, so just there's a very comprehensive comms plan, as I'm sure both Graham and I are both aware of it, but only in the background and not noticing the absolute details. So Sussex Partnership sent the initial communication to children and their families, confirming the transfer is happened and to provide the notice of data transfer on the 23rd of December. We are currently working on a web page around this. The comms have been provided to the internal children and young people staff, also on the 23rd of December. There is another notification going out about data transfer, and then a welcome to Surrey Borders for both the staff and the children and young people is going out on the 31st of this month. So there's quite explicit communication, and people should have been communicated with 3 times by the end of this process.
Thank you, and I can see a thumbs up there from Rachel, so thank you for establishing that before we move on. Good. Okay. In relation to our integrated performance report, may I ask then for comments and questions? Shall I bring you in first, Neil? Thank you.
Yeah, thank you, Priya. And yeah, I think Fiona and Sarah have broadly summarised the position, but it's probably worth to update whilst we're having a meeting in public. So I think it's fair to say all sectors of the health and care system have seen growing pressures in recent years, and certainly in terms of A&E, you know, demand is up something like 20% since pre-COVID and 12% over the last year. So really significant pressures being seen in terms of the demands. I think that, coupled with the industrial action at the start of January and obviously the expected increases in acuity of patients, has led to excessive waits. And I think, you know, while we're in public, we just want to apologise for any members of the community who've had an extended wait in the A&E departments. Clearly, a lot of planning goes into preparing for what are known winter pressures. We have planned to open additional beds. I think Fiona touched on the urgent care centres that have been opened, virtual wards, remote monitoring, work around discharge. Certainly within the hospitals, increasing staffing levels, increasing new models such as same-day emergency care models have all been put in place to try and provide the best care we can in January. But I think, you know, the extent of the demand has put extreme pressure around those. In addition to that, we therefore in January significantly scaled back elective and planned work, opened additional over 100 beds now opened. That's on top of 120 that were opened earlier this year. So really increased levels of bed capacity in the acute sector as well. But as I say, that has led to extensive waits in the A&E departments. So where we are now, we're clearly responding as a system. We're on our heightened levels of escalation around that. We're doing a lot of work to try and free up the system and get some more patients back to their usual place of residence, and looking to encourage the public, obviously, to come to A&E if they have anything remotely like a life-threatening or urgent condition. But for those who can be seen elsewhere, to use the alternatives that are available. I think just linking it back to the other areas of performance that Rich linked to, you know, I'm really grateful to our teams, despite those pressures, and we recognise a lot of patients' appointments have had to be changed. We still remain on target to achieve the planned care targets this year for the NHS, which are around the maximum 65-week wait, which I think will be a real achievement for all of our teams, as well as being in the upper end of performance around cancer and getting back into the pack around diagnostic weight. So we clearly need to be mindful of all areas of performance, recognising the improvements we need to make around urgent care.
Thank you very much, Neil. Very clear and comprehensive. Can I ask for other comments and questions? Ilona, please.
Thanks, Priya. Sorry, excuse me. Thanks, Neil. Really helpful to get your update. And this isn't a question straight back to you necessarily, but I was really pleased and heartened by our progress in relation to virtual wards and remote monitoring. So my question as a non-clinician is, are we pushing that as a system as hard as we should? Or, you know, what given we're already performing well there, can we take that further faster? And ditto on kind of the more upstream preventative measures, so that we do everything we can to keep the pressure away from your collective front doors, Neil. Thank you.
So
I think Lisa was going to come in there, Priya. I think it's probably,
Yes.
probably best.
Come in, Lisa, and then Fiona.
Yeah,
And
thank
then
you.
Ash. Thank you.
Can do. So remote monitoring is really being looked at very, very positively across all our 5 places. I can confirm that we have a little over 7,000 patients who are in remote monitoring. And just to remind everybody, this is specifically offered to patients who are at higher risk in the community, so the elderly, the frail, people with multiple comorbidities and so on. And clearly when they deteriorate, early deterioration is picked up, so to stop them from deteriorating further and getting admitted into the hospital. So when they are picked up early, the remote monitoring teams respond, primary care is involved as and where need be. We've had some lovely positive stories, both from frontline clinicians and also from patients, as to how they've benefited from the remote monitoring and step up into virtual ward and step back down if their condition allows it. So all of that work is motoring along while we do the prevention aspects of it. And in fact, for example, something like the digital weight management service, nothing to do with the frail elderly, but general holistic health. We are quite high, and in fact, we were the highest in the Southeast region at one point. And nationally, some of our places are at 4th or 5th place, even within the country. So I think it has to motor along as not either or, but alongside while we look after the left and the right of the curve of care, I think.
Thank you, Lalitha. Fiona, did you want to come in?
Yeah, it was just to express that in terms of at the moment, the pressures and the financial constraints have to be taken together. So pushing further faster in one space without modifying the whole system beyond where we've got to could create a problem for us in another space, such as financial performance. So again, we've got to, in a sense, we put as much as we can into those models, and much as we can afford for this year, including the urgent care centres and the additional beds. To go beyond that has to be part of our planning discussion and taken in the round.
Thank you. And Prash, please.
No, thank you, Elena, for the question regarding sort of in real terms, what are we achieving? And obviously this off the back of what Lalitha was talking about as well, as one of two providers in the system of the digital healthcare team, I've got some real world sort of coalface sort of reflections. So obviously a big piece of work we're doing at the moment is actually gathering proper benchmark data from the last sort of 6 to 8 months of not just the virtual ward capacity, but as Lalitha was talking about, we've led not the system, not just in the system, but actually nationally with regards to some of the anticipatory care. Because what we're trying to do is build trust with our communities so that they get used to the idea of the technology being part of the wider offer from primary care, which is essentially your first port of call is your local general practice, because we've got huge amounts of resource, we've got a valuable multidisciplinary team. But what's brilliant is by using the technology as an adjuvant, we're able to get a faster line of communication, and actually we're able to then visit and be proactive for sort of the frail and vulnerable. I was busy trying to find on my computer some of the actual data, and I've completely failed, but it's available and I'll pass it to you. But we have seen real percentage decreases in those patients calling ambulances. We've had real percentage decreases in those patients ending up in ED. We are getting real levels of reassurance within the community. So what's quite exciting is that by placing some of that technology in our community's hands, they're actually starting to, across the board, reduce their sort of helplessness, as it were, because the technology itself produces a level of reassurance, and we've got that data now in the system, which is very exciting. And just that final point with regards to what Fiona's talking about is really looking at this in the round, because some of the work that we're certainly doing now is trying to understand what that business case looks like in the next financial year, and trying to understand how we can start making this work within the system itself. Because really the benchmarking that we need to do, and again, this is what Rich has talked about, is how do we start aligning these numbers with true financial return on investment. But my real belief is based on not just what we are achieving, but the investment of maybe 2 or 3% in something transformational like this type of technology is starting to show that you can maybe save 4 or 5% in the wider system budget. But it is because of the bravery of the system and our partners with regards to actually putting funding into these types of innovative projects and technologies that's not only causing some real excitement, because we're starting to see real benefit in a much shorter term, and we're able to reflect also that some of the safety issues that people worry about, we're starting to see that actually it's not just safer, but incredibly well accepted by all members of the community. So no, very exciting stuff. Just wanted to reflect real world views from one of the teams delivering the service.
Thank you very much. Really helpful to have that perspective. Any other comments and questions? So really important to see this. The performance report, the integrated performance report, is there to give us that triangulated view of performance, money, quality and safety monitoring, all of those things around workforce, etc., being brought together so that, as we say, we see that whole picture. So we've seen access to the promotion of access to right care first time, then the active management of the key areas of pressure and the key populations at risk, with initiatives, as you have identified, around virtual wards, etc., and the use of data and insight to show the impact of those initiatives so that we can continue to maximise resourcing where possible, understanding the factors that lie outside our gift control, and never losing sight of that need for upstream prevention to be invested in and worked on alongside current year delivery. So as we move through with the integrated report, the degree of detail around all of those will build as well. So that's great, and thank you for the work that's being done on that. Are there any other comments or questions in relation to system performance or any aspects of that? I can't see any on the call. Thank you. I'm going to bring that item to a close. We would have a slot on the agenda to take any questions from the public raised in advance, and I don't have any for today. So may I ask, is there any other business from board members, please? Thank you very much, and thank you again. I think let's end today's board meeting with the thanks that we started with. There's a lot of pressure for everyone across the system, our teams, our patients, our residents, and a huge thank you to everybody for all of the efforts they're making to keep us safe and high quality and getting through to giving patients and people the right care first time. Thank you all. Take care. Have a good rest of the week.